Hello, and thank you for viewing our team presentation on post-traumatic stress disorder, the neurology, pharmacology, and treatment. Our patient is Patty. Patty is a 32-year-old Caucasian female with a prior diagnosis of post-traumatic stress disorder, first identified around age 23 after a traumatic sexual assault at a fraternity house during college. She never reported the incident and ultimately left school. Since then, she has lived with persistent trauma-related symptoms. Patty describes frequent nightmares, flashbacks, hypervigilance, and avoidance of trauma reminders, including college-age men, college campuses, and certain television shows. She also states, "I am so nervous all the time I can hardly do my work," and "I can't live like this anymore. I feel like I'm going crazy." She is not currently taking psychiatric medication and has previously attempted counseling but discontinued treatment due to difficulty with exposure-based therapy. To manage her sleep, she drinks a bottle of wine nightly, though she reports it no longer helps and fears her intake may increase. Socially, Patty has been married twice, with both marriages ending in divorce. She has no children and currently works for her mother. She reports feeling close to her 3 brothers. On mental status exam, Patty is oriented with congruent speech and affect. She presents as anxious and fidgety, constantly shaking her left leg. Her thought process is organized and her memory and concentration are largely intact. Her labs were within normal limits. Post-traumatic stress disorder, or PTSD, is a stress-mediated chronic mental disorder that results from direct or indirect exposure to a traumatic event or events. PTSD is characterized by a collection of symptoms, including anxiety, irritability, negative emotions, re-experiencing, avoidance, insomnia, personality changes, and memory problems. The pathology of PTSD is complex and poorly understood. However, there is evidence that points to dysfunction in brain systems involving the prefrontal cortex, hippocampus, and amygdala. Dysfunction in these brain areas result in diminished executive function, memory difficulties, enhanced fear retention, and poor fear extinction. The prefrontal cortex, particularly the ventromedial region, is underactive, limiting top-down regulation of fear and emotion. Decreased communication with the amygdala results in retention of fear extinction memories, inhibition of fear expression, and poor emotional regulation. This disconnect creates difficulty distinguishing real and perceived threat. The hippocampus is involved in memory consolidation and fear extinction. Dysfunction in these pathways is involved in the overgeneralization of fear in PTSD. Chronic stress exposure results in high level of glucocorticoids, and this is linked to reduced hippocampal volume and increased vulnerability and impaired contextualization of trauma in PTSD. Hippocampal atrophy and functional deficits have reversed after treatment with SSRI in some preclinical studies. In PTSD, the amygdala is overactive, amplifying fear, threat, perception, and emotional reactivity. Decreased communication with the prefrontal cortex and hippocampus allow an unregulated fear response by the amygdala. Catecholamines in PTSD. Trauma and stress increase the release of dopamine and inhibit communication between the amygdala and prefrontal cortex. An increase in dopamine interferes with fear conditioning in the mesolimbic system. In stress, norepinephrine is released by the adrenal medulla and sympathetic nerve endings. An increase in norepinephrine levels and activity increase the startle response, arousal, pulse, and blood pressure, as well as the psychological response to memories. A decrease in concentration of serum serotonin is found in patients with PTSD. This deficiency contributes to the dysfunctional dynamic between the amygdala and hippocampus. Low serotonin can also further increase startle reflexes, impulsivity, and memory intrusions. GABA plays a role in neuroplasticity and the formation of fear memories in PTSD. It is theorized that a misbalance and loss of homeostasis between excitatory and GABA inhibitory signals is at fault in PTSD. However, drugs that regulate GABA and have the ability to restore some normal GABA function also have serious side effects: drowsiness, fatigue, and dizziness. Although downregulation of GABA could be implicated in PTSD, the risks of using medication in an attempt to restore baseline neurology outweigh the benefits. Glutamate, the main excitatory neurotransmitter in the brain, has been implicated in PTSD patients as well. A study has found that elevated levels of glutamate exist in the hippocampus of PTSD patients in comparison to patients who were exposed to trauma but did not develop PTSD. This knowledge and other knowledge of glutamate has led to studies targeting glutamate and glutamate receptor antagonism as a possible method for PTSD symptom reduction with promising results. For our patient Patty, we propose the initiation of sertraline, an SSRI starting at 25 milligrams per day and titrating to 50 milligrams daily after 1 week, assessing her for tolerance. The target dose range for this medication is 50 to 150 milligrams per day, depending on her response and tolerability. The max dose of 200 milligrams per day could be considered for Patty. After 4 to 6 weeks at a therapeutic dose, we will assess her response and consider titration if her symptom reduction is less than optimal. Patty presents with classic PTSD symptoms such as hypervigilance, re-experiencing, insomnia, avoidance, and emotional dysregulation. These symptoms reflect dysfunction in multiple brain regions. SSRIs like sertraline enhance serotonergic signaling, which helps regulate these brain circuits. It reduces the startle and hyperarousal, improves her mood, and restores sleep. They are thought to improve hippocampal neurogenesis and prefrontal control over the amygdala. Sertraline is an SSRI with strong evidence for efficacy in reducing core PTSD symptoms like the ones Patty is experiencing. Sertraline is FDA approved specifically for PTSD and is recommended as a first-line pharmacologic agent in both the APA and VA DoD clinical guidelines. Paroxetine also has an indication for PTSD, but sertraline is less sedating with fewer withdrawal concerns. When prescribing a new medication to Patty, we would explain to her how the drug works in her body and the symptoms we are targeting. Side effects such as nausea, insomnia, jitteriness, and headache can be common but transient. Sexual dysfunction is often a persistent side effect with this medication. Full therapeutic effect of sertraline may not be seen for 4 to 6 weeks. It is important to continue taking the daily dose, make sure she doesn't skip doses, and don't disrupt the medication abruptly to avoid potentially severe discontinuation side effects. Abusing alcohol while taking an SSRI can reduce the efficacy of the treatment and exacerbate depressive symptoms. We would want to encourage Patty to decrease her nightly wine use while she's taking this medication. When considering pharmacological treatment for Patty's PTSD, both sertraline and citalopram are selective serotonin reuptake inhibitors. However, sertraline is a preferred choice for several key reasons. First, sertraline is one of only 2 SSRIs approved by the FDA specifically for treating PTSD, giving it strong evidence-based support for symptom reduction in this population. Citalopram, while effective for depression and anxiety, is not FDA approved for PTSD. Sertraline is also generally better tolerated in patients with co-occurring anxiety and hyperarousal symptoms, both of which are prominent in Patty's presentation. It has broader use in treating intrusive thoughts, nightmares, and startle responses, which are hallmark features of her case. Additionally, citalopram carries a higher risk of QT prolongation at doses above 40 milligrams per day, which may limit dose flexibility in cases where symptom control is challenging. Overall, given Patty's clear PTSD symptom profile, high anxiety, and insomnia, sertraline offers the best balance of efficacy, safety, and FDA indication. If trauma-related nightmares persist, prazosin may be added. It is an alpha-1 antagonist shown to improve sleep quality in PTSD patients, particularly those with combat or sexual trauma-related flashbacks. The starting dose is 1 milligram at bedtime, titrated to 3 to 6 milligrams per night, with caution due to the potential for hypotension with this medication. Additionally, Patty may benefit from trying different types of therapy to process her memories and work through her trauma. trauma-informed therapy models can avoid traditional exposure, such as EMDR or modified CBT. The effects of an SSRI may support engagement in therapy by reducing emotional reactivity and increasing tolerance to distress. Thank you so much for watching our presentation from Dan, Jordan, Jorge, and Whitney.